CXCR4 increases. Even though the CXCR4 increases, if the stromal right factor is less, it makes the stem cells more mobile and egress into the peripheral bloodstream. That's one of the mechanisms which is commonly quoted, even though the right mechanism, or this is the only mechanism, is still eluding. It also increases the matrix metalloproteases, which is basically a protease which cleaves those enzymes, which binds them to the bone marrow niche and sets some releases them from the bone marrow into the peripheral bloodstream. And there are other ones like very late antigen, VCAM bindings, and all those things helps in mobilizing stem cells in GCSF, but that's fundamentals of GCSF. The newer drug, which is a CXCR4 inhibitor, the plerixafor or Mozobil, which was the innovator molecule which came into use, actually it still actually interacts with the SDF and the CXCR4. The CXCR4 which are expressed on the CD34 cells, and the SDF one which are expressed on the stromal cells, as I said, helps them in a tight embrace. And plerixafor basically disrupts them. So if you use plerixafor and GCSF together, it has got a significant synergistic action. Not only helps in releasing the stem cells from the bone marrow niche, but also helps them mobilize into the bloodstream. There are still concerns. I mean, plerixafor and GCSF. The commonest adverse events of GCSF, as you all know, is high white cell count, increased bone pain. Rarely splenic ruptures have also been mentioned. But these are all very rare side effects, and many of them can be managed with simple analgesics and fluids and all those things. Plerixafor is a very useful molecule, always given as subcutaneous. There is increasing evidence of giving intravenous also has a predictable levels, but as of now, the registry trials which had the FDA and the MHRA approval are all based on subcutaneous doses at 0.24 milligram per kilogram, and then dose them on the day before your stem cell harvest. Plerixafor, there are concerns about plerixafor mobilizing tumor cells, in particularly leukemia cells and myeloma cells, and there are, if you could remember the initial chemotherapy called the FLAG or the FLAG-IDA, the GCSF there used in FLAG was used as a chemosensitizing agents for fludarabine and high-dose cytarabine. Plerixafor has been used in a few trials nowadays in phase 3 trials as a sensitizer for chemotherapy to use in leukemias and myelomas. So we haven't got data on how much, there are data supporting that there isn't a huge mobilization of disease cells with plerixafor, but this has been studied, and probably another 5-10 years will tell us whether they have mobilized and they are any inferior to the regular chemotherapy GCSF or GCSL1 mobilizing agents. This was the landmark paper which led to widespread use of plerixafor by De Persio et al. This is the clinical trial on both failed mobilizers and upfront mobilizers in NHL and myeloma. The mobilization protocol consists of 5 days of GCSF. On day -4, close to the middle of the night, use plerixafor as subcutaneous injection, and as you can see, the CD34 egress in the peripheral blood happens around 4 to 12 hours after plerixafor injection. So if you mobilize your stem cells at least around, say, 9-10 hours after your plerixafor injection, you will find the CD34 reaching the maximum value during peripheral blood stem cell harvest. So give at around, in our unit, we start at around, we give the plerixafor 4 days of GCSF. On the 4th night, we give plerixafor at 11 o'clock. Start the harvest process at around 8:30 to 9 o'clock in the morning. So around 8, 9, 10 hours after one, just before it reaches the peak, and then 12 hours, and then starts to tail off. So that gives you around 4 hours of maximum CD34 circulation in the bloodstream. So 4 hours is enough to do 2.5 volume stem cell harvest. So, as with the trial data, the one which led to the use of plerixafor, the initial paper used 4 days of plerixafor, but as you can see, 4 days of GCSF and plerixafor on the 4th day provides the maximum stem cells on day 1. This is plerixafor GCSF and placebo plus GCSF. On day 1 and day 2 are the maximum, that's the day 5 of GCSF or day 1 of plerixafor, provides the maximum CD34 cells in the peripheral blood. Can we predict our harvest? How do we successfully harvest? I mean, if you have a patient, if you have a harvest done, if you have a transplant unit, you will know that how expensive these drugs are, how expensive it is a single day of harvest leads to. So you need to know when you need to harvest. If you are going to harvest at the right day. The kits used, the manpower used to mobilize stem cells, the CD34 estimations on that day, and the cryopreservation of the number of bags and other things have got significant implications on cost of your harvest. So if you can predict a successful harvest by something before putting the patient on a machine, it would be extremely useful. In centers which have access to flow cytometry which can estimate CD34, pre-harvest CD34 estimation is extremely useful to put them on the machine. A CD34 count of around 10 or more than 10 is essential for having a successful harvest. If you are going to mobilize at least 2 to 3 into 10 to the times 6 CD34 positive cells per kilogram, you need at least 10 or more of peripheral blood CD34 on the circulation, ideally 25 or more. In research poor setting where you have only the hematology analyzer, can we do that? Can we roughly guess from the white cell count? Can we roughly use these new high-end machines to predict whether you will have a successful harvest on a particular day? Machines like Sysmex and all those newer machines have a newer channel called the HPC, or the hematopoietic progenitor cell line, which is the commonest, I mean, all the Sysmex and all those things, these are the commonest machines used in our routine hematology lab. The HPC channel gives you a rough idea whether there is enough progenitor cells or enough nucleated cells in the stream, where you can estimate it and then use it as a surrogate marker for the CD34 in the peripheral blood. There are studies which use these newer analyzers to judge whether you can collect enough harvest. And again, like CD34, pre-harvest CD34 in the peripheral bloodstream, HPC of more than 10 into 10 to the times 9 can roughly predict your successful harvest, which Kishore has proved successfully in one of those papers where the HPC channels can be used as a rough guide or a surrogate marker to see whether you can have a successful harvest. Now, you have done your harvesting the patients. On the first day, you have a CD34 count of X. Is it enough for a transplant, or how much do I need the stem cells? That's a very difficult decision, as there is no single point which says that this amount of CD34 positive cells is adequate or this amount of CD34 cells is too high. There are papers which say in allograft, particularly the sibling allografts rather than the T-replete allografts and other things, the higher the number of CD34 in your product, the chance of graft versus host disease goes up. But in an autograft, nothing happens. So the higher the number of CD34 positive cells, the better chance of early engraftment and reduction in significant hospital stay, as well as morbidity and mortality. So engraftment dose, there should be a minimum dose, and there is ideally no maximum dose on a stem cell harvest for an autologous transplant. The minimum dose for a autologous transplant is 1.5. There are centers which use 1.5, but in India, where the MDR bugs are extremely common, even 1-2 days of slow engraftment leads to catastrophic results. So ideally, in an Indian setup, we should aim for at least 2, or if not 2, 3 or more. There is no... there is actually no significant linearity in the CD34 dose and the engraftment days. But people have looked at total nucleated cells, CD34 cells, colony forming unit cells, all those things, and see whether there is a pattern with engraftment. And this is the scatter plot which shows the colony forming units and the TNCs and CD34 have a rough correlation. The amount of CD34 which you collect and reinfuse reflects on the engraftment days. So for the platelets as well. The Kaplan-Meier curve clearly shows a reflection on the CD34 dose and your engraftment days. If you have an adequate amount of CD34, say around 2.5 to 3, generally you start to engraft by at least the neutrophil engraftment by around 11-12 days. We used to say around 14 days, but neutrophil engraftment, sustained neutrophil engraftment of more than 200 to 500 or 0.2 to 0.5 on 2 consecutive days with or without colony stimulating factor is considered as engraftment. So you can have a sustained engraftment from day plus 10, 11, 12, and some of them have engrafted on day plus 9 itself. The people who are mobilized extremely well and who are a high stem cell dose do well. But beyond a certain level, say if you are having a CD34 dose of 20 or 25 and a CD34 dose of 10, there isn't a huge difference. It reaches a plateau after a certain time. So there is no point in trying to mobilize more and more by putting through the patients to various different days or high volume, low volumes, and 3-4 days in succession. It doesn't help. So one single day high dose collection is adequate if it is more than 5, and you can safely expect engraftment as soon as possible. This is similar for the platelet engraftment kinetics as well, according to the CD34 dose. Now you have collected enough stem cells, and what do you do? This has been a running debate on cryopreservation of stem cells in India. Working in UK, the cryopreservation is a standard for all types of autologous transplants, be it is myeloma or lymphoma. Patients go and have a harvest of the stem cells. The NHSBT, which provides the transplant apheresis services for all of us, stores the stem cells in them. You send the patient home and you ask them to come back about a month later or 2 weeks later after they have a holiday and other things. You give the cells back if you have adequate stem cells, thaw them and give it back. In India, that means that there are 2 visits to the hospital and 2 or 3 admissions in the hospital, and becomes prohibitively expensive to cryopreserve all of them. So if you have collected enough amount of stem cells, and if the quality of the stem cells is always good if it is a single harvest. More and more harvest days actually reduces the quality of the stem cells. Even though you may hit a quantity of around 5, 6, 7 or something, a single day 5 into 10 to the times 6 is significantly superior to 3 days of 5 into 10 to the times 6. So if there is a good quantity and quality of stem cells on a single day, can we use these cells without cryopreservation? Uncryopreserved stem cells are viable for up to 96 hours. In fact, they retain most of the viability up to 96 hours. People who have used stem cells after 96 hours start to have a very late engraftment, which can have significant impact on outcome of your transplant. So you can use anywhere from 24 to 96 hours at 4 degree in a conventional blood bank refrigerator. You can store your stem cells at 4 degree in a conventional blood bank fridge for up till 96 hours, but I wouldn't venture out beyond 48 hours, as it becomes very difficult to check the viability appropriately. And so if you are going to do a myeloma autograft, you mobilize them with GCSF or chemo GCSF or Plaraxivir GCSF. You harvest them on a particular day, and if you have a successful harvest, you check the harvest product of CD34. If there are adequate CD34 cells, you can give melphalan or high-dose melphalan on the same day, and 24 hours later reinfuse the stem cells which you have stored at 48 hours in a blood bank fridge. So that makes the transplant extremely simpler. 5 days of GCSF, get all your pre-transplant investigations, everything done, harvest on one day, give melphalan, give the 24 hours later the stem cells, they engraft by 10-11 days. So you would be able to do a stem cell collection and give the high dose melphalan and then send them home around 10, 12, 13, 14 days after transplant. So that hardly lasts 3 weeks. In fact, less than 3 weeks. That saves a lot of money and patient transports and other things. Suppose you have a patient who have a ropey collection either due to melphalan or have a significant cytopenia at the end of chemotherapy and can still mobilize stem cells but can't have the transplant on a particular day, you need to cryopreserve. Or if the conditioning regimes is going to be for about 6 days or something, you have to cryopreserve stem cells. Cryopreservation has its own problems. You need to find the appropriate cryoprotectants. The commonest used ones are the DMSO along with albumin and saline. Why do we need a cryoprotectant? The stem cells are extremely temperature sensitive, or in fact all the nucleated cells are extremely temperature sensitive. If you freeze them quickly, the cytoplasm develops icicles and then breaks the stem cells and they lose their viability. So you need some cryoprotectants to preserve those stem cells at deep freezing, and DMSO, which is the dimethyl sulfoxide, is the commonest one used. So use a cryoprotectant, mix them with the DMSO